Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH, or more broadly, fatty liver disease, surf's up, because episode 38, the wrap-up episode for AASLD 2020, is live now. So it's now Tuesday for us. It'll be Thursday when you hear this. AASLD ran from Friday to Monday. It wrapped up yesterday. We had sessions Saturday night, Sunday night, Monday night. Thank you for listening and for your kind comments. And today we just wanted to do the same thing we did at the end of EASL because it worked so well, which is to invite back our friends Vlad Ratziu and Jörn Schattenberg to come in, share with us whether they found a presentation or poster particularly interesting or helpful that they thought we should share. And then we're just going to all talk about what we learned. Donna is, again, not with us today. Hopefully she'll be back soon. But Louise and Stephen are. And as I say, Joern, how are you doing tonight?
Yes, I'm up. Thanks. I'm fine. I went for a run before this, so I'm all excited and energized now and ready for the next hour.
Excellent. And Vlad, how are you tonight?
Very well, thank you. It's been a long day, but looking forward to have this discussion. I can't get enough of Stephen. I heard him for like 3 or 4 days in a row, but I'm very happy to hear him again presenting.
Well, tonight he's not presenting. He's just kind of chatting. Stephen, you're not presenting tonight, are you?
No, I'm just listening. I'm learning from my colleagues.
Excellent. What you all missed was a very quick consult before we started with Stephen asking Joern and Vlad for feedback on a challenging patient, and Vlad coming up with a really interesting solution. So with that, why don't we just get started? First question going around, same question we've used for the meeting, but so Louise has practice and so does Stephen. But so what was the one most interesting or intriguing thing you heard or learned during this AASLD 2020? Brave one, go first.
Vlad is silent, so I'm going to take a first shot, I guess. I think I'm thrilled by the number of therapeutics we've seen emerged, and also you guys discussed on this podcast previously. We're seeing a real armamentarium emerging here to treat steatohepatitis with fibrosis specifically, and I think that's very exciting, be it combination, be it drugs that hit difficult endpoints. So I think this was a really interesting meeting for me.
You know, Joern, to your point, I counted over 10 clinical presentations on different mechanisms of action to treat NASH and or fibrosis, to include, believe it or not, some pure anti-inflammatory plays. And a lot of us kind of thought maybe that's, old news, but we've got some interesting inflammatory plays coming. And then also, and in addition to all the top line data from, the other big players, the pan-PPAR, the GLP-1, PPAR alpha delta, the FASN inhibitor, FGF21 work, some more data on FXRs, and then the combo data, and then FGF19. So lots and lots of data. To your point, I think it was probably one of the most data-rich conferences, so much so that, the phase 3 elafibranor, granted it was a negative trial, but it was relegated to a poster.
I was also very surprised in a very pleasant way and excited by the very large variety of drugs that are being presented as candidate therapies for NASH. So this is absolutely amazing, especially when you look back at what the field was 10 years ago. So yes, very large number of drugs. Some combination therapies, not so many, but most of these drugs that are now in phase 2 that look very promising. So the field is really flourishing, and I think we should have hope for the future. I also saw a few interesting presentations about diagnostic methods, either based on gene markers or based on some very fanciful biomarkers such as cell-free RNA. Yeah, and then some other presentations also on more usual biomarkers that are being tested in the setting of a clinical trial and in trying to see whether they predict response to a drug. So all this is very exciting. Unfortunately, these meetings grew now, they're now so big that most of the attention focuses on the oral presentations, and unfortunately many posters are just going unnoticed because we all have very limited time. And the virtual format, the digital format this year makes it that we probably dedicate even less time to the meeting, because when you have to travel somewhere and you go for a meeting, you're there and that's all you do during a meeting. But here we all went around our usual business in addition to attending the virtual meeting, so there's less time to look into the posters, and I'm sure I've missed a lot of them that are potentially very interesting. So hopefully all this will be on display on the website for a longer time.
I suppose I would noticed a little bit more of lean NAFLD and its risk of all-cause mortality now, and I suppose that will be interesting given that we struggle to diagnose NAFLD in the obese in primary care physicians. So looking in the future as to how we will target that population will be interesting. So yeah, there was a little bit more on that I noticed.
The things I noticed were the things that were kind of around the edges, lean NAFLD being one, some pretty good epidemiology on pediatric and adolescent NAFLD and how that's different, what it means. For me, Vlad, I had kind of the opposite of your experience. Usually when I go these things face to face, I'm spending enough time networking that or working on projects that aren't at the meeting that I don't get to focus nearly as much as I did here. I probably read more posters in the last 3 days than I typically read in a meeting, and made note of 15 or 20 more that I want to go back and get over the next week or two. So I think actually the format helped me at least get closer to the posters. I think each of us different, but for me that worked out pretty well. So with that as a starting point, let me first invite our European colleagues, our continental colleagues, Louise, who've not been with us the last 3 nights. Would each of you like to take one poster or presentation from the meeting that you think was important that we've not talked about in the last 3 nights? Joern, why don't you go ahead first?
Sure, thanks, Roger. And Vlad mentioned the posters, and I took this podcast as the motivation to actually dig a little bit deeper into the posters and look what we got there. And I decided to discuss one, potentially 2 posters tonight that deal with SGLT2 inhibitors. And this is not a novel drug class for NASH, but it's a drug class that's being established for the treatment of diabetes, and the class has shown survival benefits for these patients. So I think it's of great importance also to consider it for our NASH patients, of course. There are actually 2 posters, and the first one I'd like to discuss with you guys is poster 1719. This is an extension study of a large diabetes trial. It's entitled Dapagliflozin plus saxagliptin add-on to metformin maintains reduced liver fat and adipose tissue volume in patients with type 2 diabetes over 122 weeks. It's a diabetes trial with a primary endpoint at 52 weeks to show superiority of an oral regimen, namely dapagliflozin plus saxagliptin, as an add-on to metformin over the group that received sulfonylurea in addition to metformin, glimepiride. And they had a long-term extension and an MRI subgroup study on there. And I think that's what made it interesting, because you see some durability of results over a long time that we normally haven't seen yet in NAFLD trials. Now, being a diabetes study, this poster had some exclusion criteria that actually prevented more advanced liver patients enrolled in the study. They enrolled men and women with type 2 diabetes and an HbA1c above 7.5 and below 10.5, defined as not optimally controlled, and then escalated the oral treatment for diabetes. But they did not allow patients with, I quote, significant abnormal liver function tests. So that's not well defined, I found in the paper, and I actually went to the paper for the 52-week primary endpoint that's published. Didn't say there, not that I could see it. But I think the interesting part of this poster that's presented now at AASLD is the long-term extension with the Mri Substudy. And in that substudy, they actually had 46 patients in the DAPA-SAXA metformin arm and 36 patients in the glimepiride metformin arm. And none of them had a FIB-4 that was elevated. So as you could expect, by ruling out significant liver disease at baseline, none had advanced fibrosis. So that's important to keep in mind. And the study showed improved metabolic control. HbA1c was decreased better in that triple DAPA-SAXA-MET group compared to the glimepiride and metformin. And they showed actually decreased in visceral adipose tissue, subcutaneous adipose tissue, but also the change in liver fat. Mean changes from baseline were comparable at week 52 and at the end of the 122 weeks extension time. And the adjusted mean change from baseline in liver fat MRI PDFF percent was minus 4.32% in the triple group and minus 0.84 in the lim-met group. And that didn't get much better over time. So you in the end, you see a durability of effect. And if you look at ALT, for example, they had ALTs presented. What happens is in the first 12 weeks in that triple group, DAPA, SAXA, MET, you get a drop in ALT that's moderate, minus 5 on mean. And then it stays flat over the time of up until 156 weeks. So I found that interesting. And it tells me that, either if you consider SGLT2 as a treatment, as a metabolic treatment for patients with mononuclear fatty liver disease, you get a max out effect. And it actually sets in fairly early. So what I can see from the ALTs, it's maxed out at 12 weeks, and the MRI PDFF at 52 weeks was the maximum effect they showed. It didn't get any better by looking up until 156 weeks. And, with all caution, because that's a highly selective, it's a diabetic study population, not a liver disease study population. I thought it was interesting to see such a long-term effect and a durability of effect from those drugs. Just to mention, I think there was a second poster, Dr. Harrison presented on lycoglyphosine, poster 1677, that I'm just going to mention briefly here because it's the other SGLT2 inhibitor that I found data on during the study, and it showed effects after 12 weeks. And if you look at the ALT, everything happened back then already. So I think for me, SGLT2 as a treatment paradigm and non-alcoholic fatty liver disease, yes, but what it looks like, and if you look into that long-term extension, you get a certain durability of the effect, and it's maxed out at one point. So that was my take home from those posters.
Fascinating stuff, and those are important, certainly in the context of diabetes, very important drugs. Do they tell us anything more generalizable?
So you have to be careful to extrapolate anything with regards to liver disease from that, because really, as I mentioned at the beginning, I think this is a diabetes study. What you see, if you optimize the treatment, and you think of it, in the discussion of is who do you enroll in a NASH trial? It should be a patient with an optimal control of diabetes. So if you look into this diabetes study, they had an HbA1 of 7.5, and if you add on a drug, then looking at ALT, you get a maximum effect at 12 weeks. And I think this is what we normally do in trials. If we adjust the patient and stabilize the metabolic condition, optimize the treatment for NAFLD, the protocol defines a stability of the COMATs for diabetes for 12 to 24 weeks. And if you respect that, you don't get any additional effects that could affect your primary outcomes. So if you look at it from another way, this could be one information that you pull from that diabetes study. By adding even an SGLT2 here, you do not get noisy signals with regards to the endpoint that you might want to be interested in, studying a total different mechanism for NASH treatment.
So, Joern, do you think the main advantages of those SGLT2 inhibitors is mainly weight loss, and it doesn't go beyond that?
I would say clearly they have metabolic effects, and the weight loss is supported, but I think it has to have additional effects by increasing the insulin sensitivity, and that's something they showed here in that diabetes trial with that triple combination, and it wasn't an SGLT2 by itself, but they added the DPP4. You also get improved insulin sensitivity, and I think at that level they showed, and I didn't go into that too deep, but they had decreasing visceral adipose tissue and the subcutaneous fat. So I do think you get additional metabolic benefits that in the long term can lead to some stability in liver, or let's say metabolic control, but no direct liver effects as far as I could tell from this poster here.
So, Joern, thanks for highlighting the poster, the work that we did with the word. It's hard to pronounce, lycogaflosin. So it took me about 100 times to learn how to pronounce that accurately. But interestingly, it's a dual SGLT1/2 inhibitor. So it's a dual inhibitor of the sodium glucose cotransporter, basically working in the intestine as well as in the kidney. And when it was a small trial, but it showed some pretty interesting reductions on liver fat. In fact, the relative liver fat decrease with the highest dose was almost 39%, with almost 67% of people achieving a 30% relative liver fat reduction, which is kind of on par with a lot of the data we saw in early phase being presented on the oral stage at AASLD. And to your point also, it's now being looked at in combination. So Novartis is looking at it in-house with their FXR tropifexor, which Arun Sanyal presented on, and didn't seem like it did as well histopathologically as they were hoping for. But maybe in combination with this SGLT1/2 inhibitor, there might be some positive data. That trial is called the Elevate study, and it's currently ongoing and in clinicaltrials.gov.
Yeah, I agree. And the shorter trial, I was just to follow up, is obviously a very different study population that you enrolled here, Stephen, because that was a typically NASH study population with histology or phenotypic diagnosis, elevated ALTs. So patients that do not normally get into a diabetes trial. And again, a different mechanism here with the renal effects too. But back to Vlad's point, I think something we see is a predominant metabolic effect from this type of class here. And how does that relate to long-term effects in the liver? I presented the other poster because I thought it was interesting that you actually do get some data long-term, 154 weeks, and there seems to be a durability or nothing that happens more after a certain time point.
You think of SGLT2s. I tend to think of cardiorenal effects secondary to diabetes rather than liver. But so Stephen tossed out in a brainstorming conversation about directions we should go maybe a month and a half ago that hepatorenal might be an interesting one. And I wonder if there's an interplay between the cardiorenal effects of SGLT2, particularly in diabetic patients with fatty liver, that might be at least conceptually helpful. Is there a self-evident way that those pieces might fit together, or am I just completely kind of barking up the wrong tree?
I do see NASH as the concept of metabolic inflammation, and for sure there's a certain link. I don't think we're in the position today to nail that or say how the interaction exactly can be modulated therapeutically. We're talking about better metabolic control, improving HbA1c, insulin resistance. For sure, that links through the metabolic control these organs. We do not fully understand how liver kidney could interact here directly, as far as I understand. Maybe the other guys want to give their thoughts to that, but it's an interest. I think it's something we're going to learn more as time goes by.
I think I brought this up a while back, Joern. It's just, we all give talks on NASH, and we talk about the extrahepatic manifestations of disease. And we often look to the cardiac manifestations. We look at obstructive sleep apnea, polycystic ovarian syndrome. But the one thing that the literature keeps spitting out over and over again is this association with chronic kidney disease. And I guess maybe turning the question around a little bit, using SGLT2 inhibitors for the treatment of fatty liver, knowing that maybe they don't have as robust effects as some of the other data that's been presented, in combination, do you think there's an opportunity for us to mitigate some of the negative downstream effects that this disease may likely have on kidney function?
I agree, and I think I can follow that way of thought. That we actually did do an analysis on chronic kidney disease in a German population that's followed in primary care, and we did see an independent effect of non-alcoholic fatty liver disease on emerging chronic kidney disease. So I am totally on your side. And the tough part has been, to decipher what part of the hepatic inflammation does contribute to that. And if you have a drug that's beneficial for metabolic control, like the SGLT2s, and if you improve endpoints and kidney function in the end, could also benefit. So yes, I don't see the direct link yet. So that's, I guess, where I'm trying to tease this out in patients. A lot of the data comes from animal models, and we learn from those, but it's difficult to pinpoint it down. But in general, yes, I agree, Stephen.
Yeah, I'm a little puzzled by the SGLT2 inhibitors. I mean, definitely I can see the benefits of using these drugs in diabetics because of the cardioprotective and renal protective effects. Regarding NASH, I'm not aware of any good studies with liver outcomes that have looked specifically at the efficacy of these compounds versus placebo, and I'm not aware of any study with histological outcomes as well. So while waiting for that, we have to sort of anticipate what the beneficial effect would be based on the weight loss they clearly induce. I was looking at your poster, and I see that the weight loss is around 4% with glycoglyphosate. If you look at figure 2, body weight drops by percent change from baseline of 4-5%, which is not that dramatic if you compare with other agents that are in development, but of course which are injectable. So I think it's a very complex equation because, first of all, these drugs are intended to treat diabetes, and people with diabetes, at least the prescription of these drugs will be done by diabetologists. So we will have to deal with it whether the patient has it or not. So So the first thing is that we don't really control ourselves the prescription of these drugs. The second point is that is there any other beneficial effect beyond body weight loss? Because then you have agents that induce a much higher degree of body weight loss. So that would be one thing. The second thing that we need to take into account. The third thing is, do they have, of course, systemic benefits that go beyond the liver that might tip the balance in favor of using these rather than some liver-targeted drug that does not directly impact cardiovascular outcomes or renal outcomes. So all this is very complicated for the moment. One other thing that is good about these drugs is probably they're better tolerated than the GLP-1 injectables. So that could be an interesting advantage from using them. But I find it complex for the moment to try to put all this together and find the right place for these sorts of drugs, because we have drugs that are more specifically liver targeted, we have drugs that induce more liver weight loss. So what exactly would be the advantage of these? Trying to find a good compromise between all these and use something that is soft enough with good safety profile and additional extrahepatic benefits, or are we trying to go for something that's stronger on the liver disease? So that all this I don't know yet very well.
Point well taken. Louise, do you have anything you want to add, or before we step into Vlad?
Go straight into Vlad. That's not my area of speciality.
Well done. That shows confidence in class. Well done. Okay, Vlad, what would you like to contribute, sir?
The surfers obviously covered a lot of these presentations during the liver meetings. So I think for the last day, very few things have been left out so far. But I wanted to point your attention to one drug that has been presented here, which is a pan-PPAR agonist, lanifibranor. It is mostly a European and US trial. And it is interesting because now we have all sorts of combinations with PPAR. So we started with mono-gamma PPARs, and then we had alpha-delta PPARs, then we had delta PPARs alone, and then we had alpha-gamma PPARs. So that was the glidazones, elafibranor, seladelpar, saroglitazar, and now we have a pan-PPAR. And this pan-PPAR is called lanifibranor. And this compound is particular in the sense that it is an agonist of all three isotypes of the PPAR receptors. However, it's not a very strong agonist for either of them, so it's much weaker than each one individually, the ones that I've mentioned before. But I guess the challenge here would be to come up with a chemical construct that is able to sort of mildly be agonistic for all these isoforms, hoping that what you might lose in terms of efficacy, you might gain in terms of safety and tolerability. So we're starting here with a situation where possibly PPAR gamma work quite well for the liver disease, although again, very important, I think, to remind people that we don't have good quality phase 3 trials for glidazones, for pioglitazone in particular. So everything we're saying is based on some strongly suggestive positive trials, but that are investigator-initiated or limited in number, such as the PIVANS trial. So we don't have phase 3 trial, we don't have definite demonstration of the efficacy of glidazones. So that's the starting point. The problem with glidazones, of course, they're generic, it doesn't cost much, but they have side effects that have been deemed not acceptable for long-term therapy in patients with NASH that are mostly asymptomatic and that want essentially to lose weight. So then there are several other combinations have been developed between different agonists, and this is the latest one, this lanifibranor. This was a very bold study. First, it used a different system than the NASH CRN system. It used the SAF histological classification, and it only selected patients with highly active disease. It is a SAF score that is 3 or 4 on a scale of 0 to 4, so that would be somewhere around 5 to 6 in the NASH CRN score in terms of activity score. So patients with highly active disease, regardless of the level of fibrosis, were selected in this study. And the other thing that was kind of bold to me, not to Stephen, which has done 12-week studies with liver biopsies, so quasi-instantaneous liver biopsy studies. This study was done over 24 weeks only, with a control liver biopsy after 24 weeks of therapy. So that is something relatively new in what we've done so far, because it's not easy to repeat a liver biopsy after only 6 months of therapy. So a large study, moderately large, 250 patients included, and the results are quite striking. If you are inclined to believe a smaller phase 2b study, the results are very striking, because if I look at, never mind the primary endpoint, which was just a technical thing, a reduction in the activity score, but if you look at the endpoints that matter most, so resolution of NASH, big difference versus placebo. So you get a placebo rate of 19%, and in the high dose lanifibranor you get 45%. So that's, first of all, highly significant. Second, way above the placebo. So that is something that has not been replicated in many other studies. In some way, it is reminiscent of the pioglitazone data, although the way you measure resolution of NASH was not done the same. But it is pretty much in the same ballpark. The second endpoint that is very interesting for future development was the anti-fibrotic effect of the drug, because there was a reduction in fibrosis stage of 24% in the placebo arm, quite high, but that was also overrun by the high-dose lanifibranor, which went all the way up to 42% again, so 42 versus 24, again a significant difference. What is very striking is that if you look at these two together, meaning resolution of NASH and improvement in fibrosis, that was 31% in the high dose versus only 7% in the placebo arm. So there aren't many drugs that have shown both resolution of NASH and improvement in fibrosis, significantly more so than in placebo, and this is one of them. So I'm counting on you to remind me the others. I think in a very small study where not everyone was biopsied, I think the FGF21, the exofermin that was presented by Stephen as well, might have reached that endpoint. And I don't know about, I forgot about aldafermin, but I think aldafermin as well has reached that endpoint specifically. So both resolution of NASH and improvement of fibrosis. This is important because obviously it points towards a extensive and comprehensive improvement in liver injury, since you have an improvement in both components of liver injury. But it's also important because it sticks very well with what the EMA has been recommended as a regulatory outcome. Now, going back to lanifibranor, there are two other things I would like to highlight, which is, so beyond the histological benefit, if you look at all the drugs that are in development now, some of them have an effect on histology, but no effect on lipids and glycemic parameters. Others have an effect on histology and lipid parameters, but no effect on glycemic parameters. This here is one of the only drugs, and this is probably because it associates an alpha and a gamma agonist. This is one of the only drugs that has an effect on histology, glycemic control, and lipid parameters as well, because there was an improvement in HbA1c, there was a decrease in triglycerides, and increase in HDL-C. So this looks very promising in the sense that it ticks all the boxes of beneficial response for a patient. So we will see whether these highly optimistic results from a phase 2b will translate into a larger phase 3 trial. The only problem with this drug, of course, is that because of the gamma component, it induces weight gain. So it all depends how you look at the weight gain. We still don't have all the data that is available. Clearly, there is weight gain. The issue is whether it is acceptable. In other words, is it much less than what we see with PO alone, or is it pretty much the same? And the other thing that we don't know is how many people what's the proportion of patients that have considerable weight gain, meaning more than, say, 3 or 4 kilograms. This is something that we need to look more carefully. I haven't seen that in the presentation. So if you put that aside, it looks like a very promising drug. But of course, the main first direct competitor would be pioglitazone. And here the competition is not fair because you're talking again about a generic drug that does not cost much at all. So this is one of the things I wanted to discuss, the lanifibranor results. I know a phase 3 trial is being planned, so we're looking forward to that.
Yeah, Vlad, that was a great job of working through the Lani paper and the presentation that Frank gave. And I think you highlighted a lot of really positive attributes about the study, as well as some concerns that you still have that hopefully will be teased out in phase 3. And I hope it goes on to phase 3 like you alluded to. I think one of the questions will be, how long is the phase 3 going to be? And my guess is it will be a year, but I think that's still up for debate. I think the point you made about hitting the more stringent endpoint of a combination of fibrosis improvement and NASH resolution is a big one. And lanifibranor is in rare air in its ability to do that. The others you mentioned, you're right. So aldafermin, it was 22% versus 0 for placebo. Efruxifermin also showed it, as did seladelpar, believe it or not. So those are the drugs I'm aware of that hit that more stringent endpoint. I think one of the things that I'm beginning to mull over in my mind, and I don't really have a good answer here, and I think this would be great to get the two of you, Joern and Vlad, to opine on this, because I think it's going to become a bigger issue as we pull out of AASLD and move to NASH-TAG and then into EASL 2021. And that is the placebo response rate for fibrosis in these phase 2 trials is a lot higher than what we're seeing in the phase 3 trials. Whether you look at Stellar 3, Stellar 4, Regenerate, with the one caveat being elafibranor, where in that phase 3 trial, the placebo response on fibrosis was 22.5%, something like that, %. More in line with what we see with tropifexor presented at this meeting with lanifibranor, with semaglutide. That paper is now out in New England Journal. The placebo response on fibrosis was 33%. And I just am wondering why that is occurring. And I'm just going to throw out a hypothesis here. Could it be that because we're looking at this semi-quantitatively, and we know the fibrosis is more parabolic than it is linear as we go from 1 to 2 to 3 to 4, that it's harder for placebo to show a fibrosis improvement in F3s. And that was shown in the aldafermin late breaker presentation. In fact, it was 12% placebo response in the F3s, which is more in line with what we saw with Stellar 3, for instance. And it was much higher in the F2 population. And that got me thinking, is it because it's a lot more challenging for a pathologist to consistently say it's F2 versus it's F1C, for instance? Could it be that the staining could be off, that the heterogeneity of the repeat liver biopsy is such that really there's no change at all? It's just hard to distinguish 1C from 2, and thus the placebo response rate is higher in that population, driving the overall fibrosis response rate in placebo higher in studies that enroll F2 and F3 patients. And to follow up the aldafermin data that our colleague presented in a late breaker, I've asked other companies to go back and look at this, to include GenFit, Regenerate, and others, to say, hey, look, what's going on here? Is that a plausible reason? I just want to throw it out there to see what you guys think.
If the point you're trying to make is how come we get more placebo response rates in phase 2 than in phase 3.
Why is it more in F2s, more specifically, than in F3?
It might be what you say, although that uncertainty in deciding whether it's 2 or 1 should apply also to the active arm, not only to placebo. So you might get a higher response rate because of that frontier that is not as clear-cut, but that should be a higher rate of response altogether for both active arms and comparator. It might also be the simple fact that with more fibrosis, it's probably easier to see whether an effective drug has an effect, because more mild effective drug or drug without any effect will not get rid of fibrosis. So it might be that in order to see a difference, you have to go higher on the fibrosis scale. But this whole thing about looking at stage 3 and stage 2 and deciding that the drug works better in stage 3 than in stage 2, and that therefore trying to take some lessons from that in terms of response to therapy or natural history of the disease, I don't really buy into that, because the way things are done nowadays with the fibrosis staging system makes it that you can't confidently make that assumption. The reason being that what people call stage 3 is something extremely wide that goes from just very early bridging with a few septa to a condition where you have extensive bridging with very many septa in the liver. So that difference in the amount of collagen and fibrotic material is tremendous, actually, if you look at it. And that's the reason why this was never something that was considered for viral hepatitis, where the early and the advanced bridging states were clearly separated into two different categories. So that was METAVIR 2, METAVIR 3. Here now they're lumped together in the same stage 3 based on NASH CRN fibrosis staging system. So when you have such a wide difference in between two patients that both qualify for stage 3, you can't say much about the effect of a drug if you don't use a finer way, a more subtle way, a more granular way to look at fibrosis. So I'm a little bit uneasy about these studies that simply look at stage 2. Some people with stage 3 are much closer to a stage 2 than to the mean amount of fibrosis that you see in advanced stage 3. So it's a very heterogeneous population, and comparing that to stage 2 is uncertain because some people stay really on the border between these two.
So Vlad, I actually talked about the F2 versus F3 aldafermin follow-up last night's session. I just pulled up a couple of slides, just a couple of them while we were here. They kind of make your point, and they kind of don't. So, for example, if you're looking at 30% relative reduction of liver fat, right, in F2, placebo was 38. In F3, placebo was 12. Now, in F2, the active group was 74, and in F3 it was 56. So the F2 group was higher on both groups, but amplitude of difference was greater in F3 than it was in F2. If you look at the percentage of agents that produced a 1-point improvement in fibrosis with no worsening in NASH, in the F2 group, placebo was 31, aldafermin was 44. In the F3 group, placebo was 0, aldafermin was 30. So I think that would speak both to the point that you made, which is if one group's going to be higher, the other group should be as well, and that did happen here. But the difference in placebo was pretty marked. I don't think that makes anything right or anything wrong. I just thought that might be a helpful data point to add.
Yeah, but you're only telling the story in terms of percentage. You have to look at the number of patients those percentages apply to. So 0% out of 9 patients doesn't mean anything. If you have 18 patients, it might be 2 out of 18 or 3 out of 18. You can jump from 0 to 15 to 20%. So unfortunately, the sample size is very small.
It isn't on this slide, but I'm pretty confident because you're not getting closer to my neighborhood, that if you compare 0% on 9 to 31% on 13, that you're going to find that's statistically significant.
I think this discussion has value to it, and I think it connects to something that Vlad highlighted in his presentation of the LANI data in terms of the surrogate endpoint, looking at patients that resolve steatohepatitis and show improvement in fibrosis. And I think this is something that's been emerging in this meeting, that if we address these combined aspects, you need a drug that really changes something, pathophysiology of the drug to show both steatohepatitis flare goes down and the fibrosis is moving. And I think it's difficult to tease it apart just on the fibrosis, and it might be just much robuster if you look at those two. That's my thought here.
This might be an area where artificial intelligence begins to show us more clearly what's really happening in the placebo arm. And I think, Arun's group tried to tease that out a bit in the tropifexor study that he presented, where they did a histo index assessment of the collagen content. I think he brought up a good point also. It's something that, the evolution of fibrosis is maybe different than the resolution of fibrosis. And that maybe is something heretofore that hasn't been well understood and may play a role in what we're seeing.
All this is true, and in the end, you might be right, but I made a fast calculation. So the 31% out of 13 patients is 4 patients. So you're looking at a group of 4 patients out of 13 versus 0 out of 9. I mean, that's 4 versus 0. It might well be true, but we need to multiply this by 10 or 100 in order to be really sure that these data are meaningful, honestly. So we're looking at percentages. It's very excessive the way we're looking at percentages.
Do you, either of you know, and Vlad, you may be closer to this, do you know if Intercept looked at this in the Regenerate? I'm not aware that they did.
I think Intercept looked at that, and I think this is in one of the tables in the paper we co-authored, and the effect was with the high dose, 25 milligrams, pretty much the same in F2 and F3. Stage 2 and stage 3 favored the active dose at 25 milligrams rather than placebo.
I'm asking what the placebo response rate was in F2s versus F3s in that, and I don't recall that we had a table on that, did we?
There was a sensitivity analysis on this, and certainly the data is available, so we'll have to go back to that.
Because that would be larger data set, that and the ELA data, and even the SEMA data. if we could get at that.
Going back to the FXR, so you mentioned tropifexor. What do you guys think about the fact that, in contrast to obeticholic acid, which has shown histological efficacy clearly without going to a histoindex or this type of analysis, just on regular standard histology, after 1.5 years, there was no effect of an FXR agonist after 48 weeks or 52 weeks of treatment? How do you explain that the FXR did not work here, whereas it did work with OCA in Regenerate? Is this something of concern to you regarding all the other FXRs in the class that are waiting to be tested in phase 3?
Well, do you think it could be just because this is a non-bile acid FXR, similar maybe to the Gilead compound?
And yet it reduced a lot liver fat. So if you use the paradigm that we like to use, which is that PDFF reduction predicts histological improvement, in particular steatohepatitis, it didn't hold true for this trial. Although, again, very small trial, 30 patients per arm. How much can you hope? How optimistic can you be to hope to see an histological effect on NASH or on fibrosis with only 30 patients per arm? I mean, if you do see that, then why do we need phase 3 trials of 1,000 patients?
Well, that's a good point. But if you take that out further, Vlad, and you look at the fibrosis improvement with tropifexor, it was exactly what Regenerate showed. The problem is the placebo response was twice as high. So we didn't get stat sig out of it. The reason Regenerate hit stat sig was because the placebo response was more in line with Stellar 3 and 4. And nobody else has replicated that since then. Quite frankly, it makes me rethink a lot of this. I mean, is it that the non-bile acids aren't as effective as something like the OCA? Or is it a fluke of the way that we're measuring the endpoint?
Yeah, so I'm looking at the data here on fibrosis, specifically 25% in the high-dose tropifexor, 21% in placebo for fibrosis, 25-21.
Which is similar to lanifibranor, which is similar to Regenerate and obeticholic acid. If you look at the high-dose tropifexor, the 120 of Ella, and the 25 of OCA, aren't they all the same or within a point or two?
Well, yeah, but, again, all this is randomized, read by the same pathologist. It's not like you have one pathologist reading placebo, the other pathologist reading the active arm. So if the difference in Regenerate, because that's the key question, is the difference that we see in Regenerate real? 300 patients per arm. Yes, you have a lower placebo rate. Yes, the difference then appears significant, but maybe if you have, but maybe whatever makes the placebo rate be lower also will make the active arm be lower. And if you still see a difference, then the difference in efficacy is probably real. So I don't know how much of this can be simply explained by placebo response, knowing that being, read by the same pathologist, same conditions.
Fair enough. But can I turn it around then and say, have we hit a ceiling on efficacy then with the FXRs?
Yeah, so I think the discussion here will be in the future. Of course, we only have tropifexor with histology on after having had this large OCA trial. So we need to wait maybe for other FXR agonists to have histology data. But the question is, was OCA in fact an oddity in terms of efficacy, histological efficacy, in the sense that is this the only compound that for some reason would have histological efficacy? Or are these, as you said, the second generation FXR agonists have lost some of the histological potency for whatever reason that we might have to understand? This is a crucial question because yes, they induce a little bit less LDL excursions. They appear to be preferable, although for pruritus is questionable, though you still have very high rates of pruritus. But let's say if we want to be very nice and optimistic that their safety and tolerability profile is better, but if that comes to the expense of a lower histological efficacy, then the whole class is in trouble. And of course, OCA will be largely the winner. So it is very important to understand whether the second generation FXR still maintains some histological efficacy, and the tropifexor data is not looking too good in that direction.
Yeah, so the other thing, I mean, this evolves around the robustness of fibrosis reading. And I think another point that's also emerged for me from this current meeting is that if you get a certain degree of two-stage fibrosis reduction, this is something that you can really relate to. And one of you has that data in his mind, and how many patients actually did on one or the other FXR show two-stage reduction for the fibrosis?
For OCA was 10% or 9.6, somewhere around 10%. And for tropifexor, I don't see the data.
And tropifexor didn't show that. Efruxifermin, the FGF21, that I presented had 38% of the 50 milligram group had a 2-stage improvement at essentially 16 weeks of dosing, biopsies taken at 20 weeks. I think what that tells me is, again, just kind of reaffirming what I think I showed at the 12-week liver biopsy time point, and that is liver fibrosis is dynamic. And I don't think it's necessarily a fluke of the variability. I think it moves pretty quickly until you become, cross-linked and portal hypertension is present. But I'm encouraged on the FXR data. I am encouraged by what Naeem Al-Khoury showed when he combined, selefixor with prosocostat and the GLP-1. The synergistic effect there was pretty impressive, and you don't have to go high on the FXR. So maybe you can minimize the AE profile and optimize its synergistic effect. And I bet you, quite frankly, at the end of the day, in 5 years, my guess is FXRs will still be around, but they'll be in an additive role in some sort of fixed dose combination where it's not necessarily the backbone, in my opinion, like we used to think it would be. I think that's probably replaced by a more metabolic drug. And this one is going to come in and help augment the metabolic effects, but also it's through its action on bile acids will have more of an effect on fibrosis, I think.
So I want one comment at 30,000 feet, and then I got a question for everybody that's a different question. One of the things that keeps striking me is that we have these debates about the FXRs, but in other classes we find monotherapies that perform well enough that you don't raise this kind of question, right? We talked about lanifibranor today. We've talked about EFX and aldafermin and a couple other things over the course of the meeting. So I wonder, Stephen, if the conclusion isn't going to be the one that you just raised, which is that FXRs might not be the most robust backbone for therapy, which we thought they were going to be when we thought they were going to come first. Now they might not even come first. And clearly there are other agents, the metabolics, that produce more successful results. I do want to switch gears a little bit, though, which is this meeting covered an amazing amount of ground. And I'm wondering, if we're looking at 5 years, what are the things that we heard this week that each of you thinks will have the greatest effect on how we treat and how we diagnose and how we think about the disease?
Let me start out. And I think something that was just mentioned in the previous comment is that we use combinations. We use drugs that are efficacious at a monotherapy level, but that if you combine it, and Stephen just mentioned Naeem's combination study of the Gilead Novo combi, here you do see potential benefits. So I think that's for sure one takeaway, and I'm very glad that this combination results have been published here, and I think we'll see more down the line. There are a number of fascinating combinations being tested. We've been discussing this for a long time, but in this meeting we actually saw data, so I think this is here to stay.
So there was no data on histological efficacy with combination. The paper you're referring to did not have histology as far as I see.
Let me go past drugs and ask whether you think there's anything we've heard in this meeting that will change how we think about diagnostics, say 5 years from now.
I'm not good at predicting, but I think the advances in diagnosis and the biomarkers are important. And I think once we really start digging into these large databases from the phase 3 trials, we'll be able, hopefully, to delineate, to identify one biomarker or a set of biomarkers that predict the histological response, or at least that track with the histological changes. And that's probably the most useful thing for the field that can come out. Of course, then you have some other very fancy ways to diagnose in the beginning the state of the liver. And we have now tests that do that specifically, that are already out there to be used, like the NIS4 test or the test combining biochemistry with elastometry. But we also have more sophisticated, technologically speaking, biomarkers like the cell-free RNA that I've mentioned, that can be drawn out of circulating blood to understand the distinction between steatohepatitis and steatosis and fibrosis. And that could be in the future. That's the most useful thing for the future, in my opinion.
Do you see that as being valuable in development or commercial use in mainstream patient treatment?
Both, of course. They go together, because there's no point to have a drug if you have to do a biopsy in order for patients to get access to the drug. So if you're able to replace the biopsy in the beginning, and then the biopsy as a measure of therapeutic efficacy, then obviously it's going to have a huge impact in the way all this is handled in everyday practice. So yeah, both.
Biopsy, certainly. I guess my question was whether some of of the diagnostics that we're looking at right now, logistically or economically, are more feasible for everyday use than others?
It's a complicated question because even things that appear to be very sophisticated, if you're able to scale them to commercial use and to develop assays that are widely available and sensitive enough, then they can be used. So you don't have to go with very simplistic transaminase, platelet counts, and all that, simple biomarkers in order to hope to have a big uptake on the market. It can be something quite sophisticated if technologically you're able to size that down to something that can be done into a commercial assay. And you've seen the story with COVID. It shows that a lot of very complex molecular biology things can be worked out to be used in clinical practice and give you a diagnosis in half an hour. So yes, I'm confident about this.
So a lot of the discussion in patient management these days is, of course, diagnostics. And I think Vlad mentioned mainly blood-based markers. They're going to be the straightforward way in primary care and secondary care. And I think imaging, which has very sophisticated readouts and good specificity, is going to come in a little later. I think this is something that also relates to your question. Where do you see diagnostics? It's going to be blood-based leading in primary, secondary, and then the more specialized you are, the more imaging you're going to order down the road, I think.
Stephen, Louise, any thoughts on that? I know Louise spends a lot of time with diagnostics.
I think what came to mind was the possibility, and it was Joern's piece on the clinical characteristics used for machine learning identification of fast progression among patients with NASH. And I think we will probably see more implementation of AI in medical records in the next few years. And I think if we can use that to locate basically the missing millions, because we realistically only see the very few that make it through the pathways currently. Appreciate there is a concern that, if we find and we screen and we locate, we'll overwhelm healthcare, but we need to wake up. NAFLD, liver disease, and all of its associated diseases is overwhelming healthcare, and particularly in low and middle income countries, it has significant effect. I would like to think that AI will play a role in locating severe disease so that we can actually change their mortality and take them off that curve, or certainly give them longer, better quality of life. So yeah, AI, I think, will take a significant progression, particularly in developed world, because we do have sort of electronic capabilities in the computers and stuff, but potentially also, Steve, Roger, you brought up patient-related and reported outcomes. If they were made standardized in primary care, then AI could read all the PROs and start to select patients even better, because there was some good evidence on how those affect and are affected by people with NAFLD. We know they're affected in other areas of liver disease, but also coronary disease, mental health. So the ability of AI in the future to help us really hone in and potentially save costs is somewhere I'd like to see it going. And I think Joern's piece was very good on that.
I guess this final question, so I'll put one more round on it. We talked about drugs, we talked about diagnostics. In terms of epidemiology, or how we think about patients and the patients that we want to target, how do we envision that might be different 5 years hence than it is today?
Let me start out and pick up what's been previously said about the machine learning algorithm. I think the majority of our patients is not in hepatology care at this point, and they need to be identified outside of specialist offices. And machine learning, or some sort of computer program running in the back end of your electronic healthcare records, is going to help to flag and identify patients for referral, but you need to educate the physicians and the mindset to actually then refer that patient for more specialized testing. I think this is very important, and that will also affect the reality of patients we're seeing. Now, you're asking epidemiology. I think we're still at a point where we do not see all these patients that are out there because they're undiagnosed, and there are difficulties related to the diagnosis for the providers that see these patients.
Yeah, just a comment on the non-invasive test. We heard a lot about PRO-C3 dropping, ELF scores changing. But the one thing that I still am a little miffed about, and I wonder why we haven't seen more data on this, is the magnitude of effect change of PRO-C3 and ELF and how that correlates with histopathology. We see a lot of work now with PDFF and even ALT correlating to change in NAFLD activity score, fibrosis, NASH resolution, but we don't have any data yet. It would be nice between now and the next meeting if we could have some papers come out looking at the magnitude of effect change of non-invasive fibrosis markers or even non-invasive markers of disease activity, looking at the magnitude of effect change correlating to histopathology, like we have with MRI, PDFF, and ALT. So it would be good in the next round of papers that come out, could we get some data on PRO-C3? What is the magnitude of effect change that's important? Same thing for ELF, same thing for NIS4, same thing for FAST, and some of these other markers, even like liver FAST, which is another one by Fibrognostics. It would be good to generate some of that data, or at least as we present the data at the next liver meeting, present data on that magnitude of effect change as well.
Vlad, Joern, how are we going to be looking at patients differently 5 years from now?
Yeah, so I think 5 years from now we'll be more confident in diagnosis made histology without a liver biopsy. I see this as the big breakthrough, and we will have it will be also we will be convinced by data, but we'll also have to change our state of mind, because I don't think that any amount of data will be sufficient to strictly demonstrate the equivalence of any of these biomarkers with the biopsy as we used to do it. So there will always be some discordance between the best biomarkers and biopsy, and we'll have to live with that, and we'll have to take a leap of faith and clearly go with the biomarkers without the liver biopsy. So that I think that will happen. The most important thing would be first to identify who needs therapy, because as soon as we have drugs, that becomes the major question. It won't be so much how much fibrosis you have or how much activity you have, but who needs to be treated and who can wait. And if we have biomarkers that can help us in identifying these people that need pharmacotherapy, that's the first thing that will be used. The second question will be, okay, I treated these patients. How do I know if the drug works? So response biomarkers will be very important as well. And it can be either generic response biomarkers that apply to all circumstances, or those that are somehow more specifically validated for one particular drug. The reliance on liver biopsy will be less. We will need to adjust to biomarkers, and the two key questions that will have to be answered by biomarkers are these. And then, of course, another big part of the answer is more awareness of the disease and identifying more patients among those at risk for NASH. This does not have to do necessarily with technological breakthroughs, but it does have to do with more awareness, and a lot of work is currently being done in that direction.
Roger, just an add-on to what Vlad said, I think we will understand that the processes of fibrogenesis and fibrolysis in our patients are much more dynamic than we are currently understanding it from taking the static biopsy and being able to test over again and see some of those changes. I think this will definitely change our understanding of the disease.
Couldn't agree more. I think that I said this too many times. When I started spending time in this space 2 years ago, one of the things that struck me was how static the insights were about what worked and why it mattered. And the dynamism of all this has grown tremendously, but not nearly the level that it will need to as we get past biopsy to the point where we can, as you say, Joern, test and retest and test from multiple directions. I believe that totally. Louise, is there anything you want to add? And then I have a different kind of wrap-up thought.
Well, the only thing I'm going to add to that is Donna would be doing cartwheels that everybody is moving to beyond the biopsy if she was here this evening. So that's all I've got to add. So I'm going to do the cartwheels for her. Woo-hoo.
This is what I'm going to do for you. Okay. I hope that 5 years from now, we're looking a lot more seriously at pubertal. I was sharing yesterday the paper on that subject from Einstein in the Bronx, and the importance, people are starting to figure this out. Tony Vigliotti, for example, at Nash Knowledge in Pittsburgh, has dedicated his patient advocacy organization to looking significantly at pediatric NAFLD. But the effect that getting a bad start in your liver can have on everything that happens for the rest of your life is staggeringly compelling. We don't teach enough about diet to take care of that. This is one of Louise's major consistent points that I agree with. And we don't think enough about the importance of children in terms of 40 years from now, we're not going to be treating anybody. But the people who are treating patients 40 years from now are commenting on it, are going to be dealing with the people who are kids today. And the better a jump we can get on pediatrics, and the more we can teach people how to eat better, think better, and understand more what they're doing to themselves, I think it will dramatically change course of disease. I'd like to hope that in 5 years we're starting to look at education systems that way. Louise, did I represent it well for you?
Yeah. I think that's key. I think we're seeing life expectancy stall in the 40s already with cardiovascular, and I think we just need to start earlier. A two-pronged attack. I think I do agree with the guys that we have to find the most severe cases first, but I also think we have to be starting to prevent those severe cases so that eventually we're just treating the real liver disease that we locate rather than always trying to play catch-up, and we've got a lot of catch-up.
So with that, let's all say goodbye to the Digital Liver Meeting, AASLD 2020. I line up right next to my friend, Dr. Ratziu, and saying next year, boy, it would be better for us all to be in person. Vlad, Joern, thank you so much, and Louise, and for the late hour and all that. We will probably, well, I don't know what we'll be back with next week, but we will let everybody know. When you're hearing this on Thursday, we will be announcing what we're doing next week. By then. At any rate, thank you, everybody. Bye-bye now.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.